Good afternoon, everybody, and thanks so much for registering for this webinar today. My name is Robin. I'm Executive Director for SAOT, and we're really excited to have Gary and Mark come and share with us some new resources and information about the Driving and Dementia Roadmap. We would just ask that you please post your questions and comments in the chat. And then at the end of the presentation, Gary and Mark will have a little bit of time to be able to answer questions for you. So with that, Gary, welcome.
Thank you very much. On behalf of Mark and myself, I'd like to express our gratitude for having been invited to give a presentation today. And we very much look forward to having a chance at the end to have some dialogue and address some questions. I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands, which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. I would like to acknowledge that I am on the land of the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. I also wish to acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. I'd like to acknowledge our incredible research team that Mark and I have had the pleasure to lead. We have investigators from across the country. Also like to acknowledge our research associates, in particular our current research associate, Elaine Stasiulis, as well as research assistants and research trainees that we've had the pleasure to work with. We also want to acknowledge our funding. First and foremost, the Canadian Consortium on Neurodegeneration and Aging that's funded through the Canadian Institutes of Health Research and Partners, as well as the Centre for Aging and Brain Health Innovation, centered at Baycrest, and the Ontario Ministry of Health AFP Innovation Fund. I also want to we would like to express our sincere gratitude to the Alzheimer's Society and the numerous Alzheimer's Society organizations who have partnered with us throughout this research. What we plan to do over the next 40 minutes or so is to give you some background on driving and dementia. I will begin by talking about the development of the Driving and Dementia Roadmap, and we'll hand it off to Mark to talk about an implementation evaluation of the Driving Dementia Roadmap that we will refer to as the DDR, and he will provide you with a tour of the DDR, which is the resource that we have developed, and then he will talk about next steps. So I'm sure, as is well known to this group, driving cessation is a complex, challenging, and very emotion-laden process for people living with dementia, their family, friend, carers, but also for healthcare providers such as ourselves. And there's two critical elements: making the decision to stop driving and then transitioning to non-driving. And of course, this requires a very sensitive balance of personal and public safety issues with health and psychosocial consequences that are associated with giving up driving. So just by means of background, this was the Canadian outcome study in dementia that included people with mild and moderate dementia. And what they noted in that study, that at baseline, 28% of the sample with mild to moderate dementia were still driving, And of interest, during the follow-up for this study at 2 years, half of those who were driving at baseline were still driving, and 3 years later, a quarter of those who were driving at baseline were still driving. Now, this is a study that estimated the number of drivers with dementia in Ontario, so it exclusively looks at this one province. But we think it's instructive in giving a sense that over time, it's estimated that the numbers of drivers with a diagnosis of dementia has very significantly increased in an exponential fashion, such that we are rapidly approaching what is estimated to be just under 100,000 drivers with dementia in the province of Ontario alone. So we've established that people with dementia may continue to drive and may do so for a significant period of time, and that there's a large number of people with diagnosis of dementia that continue to drive. The reason that's of particular concern is when you look at these reviews that have been done, comparing people with dementia with controls, people with dementia have more problems with road rules, lane maintenance, lane changing, turning, especially left-hand turns, maintaining road speed, stopping appropriately, and avoiding collisions. They exhibit less attention and slower decision-making. It's been clearly shown that driving performance decreases with increasing dementia severity. And 6 of 10 studies that have been published found that drivers with dementia crashed more often than controls, anywhere between 2 to 10-fold more. And 15 to 65% failed on-road driving assessments. This is a combination of a couple studies that looked at on-road driving performance that many occupational therapists are involved in supervising. And it compared controls to people with very mild Alzheimer's disease and those with mild Alzheimer's disease. And if you look across the bottom, the failure rate clearly goes up as you go from controls to people with mild Alzheimer's disease. And if you look at the Alzheimer's disease groups, you see that there's about a third or more that actually have marginal passes, so bordering on failing. But equally important is, even if you look at the mild Alzheimer's disease group, over a third were actually clear passes. So in the mild stages, there are people that may remain safe to drive for a period of time. Of course, the challenge is when do they cross to not being safe? The other thing that's critically important for us as health providers is recognizing the numerous health and psychosocial consequences of driving cessation, summarized nicely in a systematic review by Chihuri and some work by our group with Sarah Sanford as the lead author. So people who give up driving have less social engagement, out-of-home activity, more depressive symptoms, poorer general health, poorer functional status, greater cognitive decline, greater likelihood of long-term care placement, and a greater risk of mortality. The other thing that our work has strongly emphasized is the significant emotional impact of driving cessation. And this is for all involved. For people with dementia, there are denial, feelings of grief and sadness, loss of identity and loss of self-esteem, increased symptoms of depression, and often anger directed at family members and healthcare providers. For family, friend, carers, there's feelings of loss, sadness, and grief, fear and anxiety, and often frustration, anger, and guilt. And for healthcare providers, this is an issue that creates a great deal of stress. It causes remorse. Health providers are often meant or feel like they should be advocates for their clients or patients, and in this regard may not feel that they're actually advocating for what they want, and a significant emotional strain. There are numerous challenges associated with driving cessation, a lack of understanding about the relationship between dementia and driving. No one likes to talk about driving cessation issues, and this includes healthcare providers as well, because it's emotionally fraught and difficult. There's a lack of training and knowledge among healthcare providers about how you assess fitness to drive, but equally important, how do you support quality of life after the person has to stop driving. There are few established interventions to support driving cessation. And last but not least, resources can be difficult to access. And when you can access them, the credibility can be hard to determine. So we undertook to develop a resource to support people with dementia, family friend carers, and healthcare providers in the decision-making and transitioning to non-driving. We undertook a very rigorous process. It included 5 systematic reviews of related topics, 4 of which were published. We undertook several qualitative studies. This included a study exploring key stakeholder perspectives of driving cessation and dementia with 10 health providers, 6 organizational reps, 13 family caregivers, and 2 persons with dementia. We also did a presentation of an early version of the Driving Dementia Roadmap in Toronto at the Alzheimer's Society, where we did a focus group of attendees to get some feedback. And then we examined factors relevant to effective implementation of a resource such as this, working with Alzheimer's Society staff in 4 provinces for them to provide us their feedback. We also conducted a meta-synthesis of qualitative studies that looked at key informant subjective experiences of driving cessation and dementia. Some of our key findings, there's clearly a perceived lack of education and resources for advanced planning and decision-making about driving cessation and the transition to non-driving. Facilitated discussions about driving cessation are critical for early planning, and the emphasis is the earlier these discussions can take place, the better, and promoted shared decision-making and quite a lot of clarity that to the extent that the person with dementia can be involved in the process early and participate in decision-making, the results tend to be better accepted. Addressing the emotional effects of driving cessation are as important as attending to the practical aspects. And this came up time and time again. Here's a quote from family carer: "The trauma of losing her vehicle, the use of her vehicle, was as traumatic as losing my dad. It was like losing a spouse." And finally, family friend carers need support in their role of maintaining purpose, roles, and social participation of people with dementia. So driving is not simply a means of getting from point A to B, but means a lot to people in a variety of ways regarding their self-esteem, their personhood, and these need to be attended to. We took all this information from the systematic reviews, the qualitative studies, and we developed a driving dementia intervention framework, and very purposefully divided this into the practical components, things like information and awareness about driving dementia, issues around communication, as well as mobility and community access, alternative transportation, and then a focus on emotion-focused components. These include relationships and role transitions, issues around crisis and conflict, issues around loss and grief, and identity and meaning. The next stage of the development is we undertook to identify and assess all publicly available resources and tools that address driving cessation. The research team assessed every resource that we identified based on things like evidence-based relevance and usability, and narrowed down from 75 tools to 24 tools that were selected. We then curated the tools and resources to align with the driving and dementia intervention framework that I presented. We involved an advisory group, including 4 people living with dementia and 4 family carers. recruited with the help of the Murray Alzheimer's Research and Education Program. And this group provided very important, significant ongoing feedback throughout the development of the content and design of the DDR. We also involved health professionals and driving authority, including a geriatric psychiatrist, occupational therapist, and a manager at a driving authority to provide feedback on the healthcare professional portal. We enlisted the assistance of a plain language writer who had experience with developing educational content for people with dementia to help us with wording of the knowledge that we tried to share on the web site. We also worked with web developers and graphic designers. So I'd like to now hand things over to my colleague, Mark Rapoport, who will talk about the implementation evaluation.
Thank you very much, Gary. So Gary's described the process up until the implementation evaluation. And so the next stage that I'll describe is what we did once we'd really developed and refined the Driving and Dementia Roadmap based on the feedback that and the research that we've done to date and the feedback on the preliminary version that we had. So we then launched the website, not to the public, but for this particular implementation evaluation research study. And we wanted to explore the acceptability, the adaptability, and the preliminary benefits and limitations of our website. So we, using the help, Gary acknowledged our indenture to Alzheimer's Society across 4 provinces. We had the Nova Scotia, Ontario, Manitoba, and Alberta, thank you, Alzheimer's Societies. And from those groups, we got 19 Alzheimer's Society staff members, 6 current and former drivers with dementia, and 13 family and friend carers. And the implementation evaluation, they reported high levels of acceptability. They found the DDR, some quotes are very, very useful, enlightening, absolutely necessary. They found that it brought deeper awareness and understanding about driving cessation, which impacted their approach. So for example, more diligent about observing warning signs. So some selective quotes, the DDR is helping me monitor her more. I'm going to make sure that every few months I either go in the car with her or follow her and talk to her about it on a regular basis. And then a person with dementia told us, it made me realize there's an end to driving somewhere in the future. Actually, I hadn't even thought of it. Somewhere along the line, I know I've got to stop. Gary talked about the importance of providing support for the emotions. And the feedback that we got was that the emotion-specific content provided some insight about grief and loss. It enabled family members to attend to the emotional ramifications of this major transition in life and to initiate conversations in a way that demonstrates empathy and patience. So the modeling that the website shows about that was brought to the family carers and was perceived by the patients as helpful. Strategies to remain mobile after driving cessation brought people relief and hope. The DDR gave me a little bit of hope that together as a team with my siblings, we can figure out a plan. This was a quote from a family carer. So now I'd like to show you the roadmap. You can actually see it live on the drivinganddementia.ca link. That's the URL. But for the purpose of today, I'm going to show you some features of it using this slide. So it might be better to use that link after the seminar and really take a deeper dive. And I'll just highlight some of the features for you. So when people access the website, this is the landing page. So this is the main page. And you can see it's organized into 3 portals. There's a portal for people with dementia, a portal for family and friend carers, and a portal for healthcare providers. So you as a healthcare provider may want to, you could either use it directly yourself to give some suggestions about how to assess people who are still driving, or about how to help them continue their life after they stop driving. You may also want to share the URL with family and friend carers of your patients, and they could use this part of the site to learn directly about the driving and dementia journey, and they could in turn send it to their person with dementia, show them that part of the portal. So it's meant to be used by the three different groups, but the people towards the right of the page can share it with the people towards the left. Another important feature to know about the structure of the website that we really got this feedback early on from our advisory group is that we need a separate portal for people with dementia who are still driving and people with dementia who are no longer driving, just as we need a different portal for family friend carers and people with dementia. Different language is used for the different portals, and different issues come up depending on whether you are still driving and no longer driving. So that feedback that we got in an early stage informed the overall design of the website. So you would click, for example, if you're someone with dementia who's still driving, you might click here and see what happens. It then opens up another landing page for people with dementia who are still driving. And there are 6 options, including understanding how dementia might affect my driving. How do I recognize when I'm unsafe to drive? How do I get around without driving? How do I deal with these emotions? What about licensing and reporting? But let's say the person wants to learn about how do I get help deciding to stop driving? How do I learn about that? So that will open up, if they click there, that'll open up another page about getting help. So you can see some of the language here is written in dementia-friendly language. Deciding to stop driving can be a difficult decision. Make sure to get support. So you can click on talk to someone you trust. More information will accordion out there. Talk to your doctor. Try these worksheets. And then in the worksheets, there's a bunch of them. Here's one example, the Dementia and Driving Decision Aid from University of Wollongong from Victoria Trainer and John Carmody is a PDF that opens up, and it helps people weigh the pros and cons of continuing to drive or stop driving. And it allows you to take control as the person with dementia of that situation, presuming that they're at an early enough stage where they can make decisions. At a certain stage of dementia, obviously moderate or severe dementia, it's no longer safe to drive. We're hoping people will access this early on in the course of their dementia. I'm sorry, I've zoomed in. I don't know if that happened on your screen too. Just bear with me. I'm going to go back to full screen. Am I still sharing my PowerPoint screen and only my PowerPoint screen?
Yes.
Thank you. So back to the landing page. Let's say you're no longer driving. You might want to click here. There's fewer options to learn about. Why did I have to stop driving? How do I deal with my emotions? And how do I get around? So let's say they click there. Well, here's a list of different ways to get around. There are some worksheets. This is an alternate transportation worksheet. So as you're looking at that, I just want to emphasize what generally happens in dementia is that the transportation plan is my spouse will drive me everywhere. That's a recipe for disaster. It's a lot to put on one person. Typically, we need to have some alternatives to the spouse caregiver so that there's other people that can help. Sometimes the spouse caregiver is unable to drive, and then it turns to one family member, usually a daughter. That's also something we want to avoid, that it's just one person. The plan is a diversified alternate transportation plan. That's a more sustainable option. It gets around the ideas about guilt that the person with dementia often has about burdening. They sometimes will use the word that they don't want to be a burden to their family member, even though the family member doesn't perceive it that way. There certainly is, it is a daunting task for one family member to take on. So diversifying that is the main recommendation that we have. These worksheets, in this one example that you see here from the Hartford, gives some suggestions. So you fill out who are the family members, what are their phone numbers, and when are they available, and what's the cost, pros and cons. Of course, there may not be a cost for a family member, but a taxi car service would have a cost. Mass transit, there might be some pros and cons about mass transit. How will I get out of the vehicle and get to my appointment because I'm disoriented, for example. So I've shown you the dementia portal. Let's look at the family friend portal for a family friend care of someone with dementia who is still driving. So there's, again, a parallel number of options. And one thing that the family members are often interested in about, how can I have a conversation with my loved one about giving up driving? This is something that family members want to learn about. Well, we have some resources, including some very helpful videos that give some modeling about a good way to approach this and get around the defensiveness that often accompanies these conversations. So in this video, the conversation doesn't start out so well. There's a defensiveness, but they use some strategies to move the conversation along. So on this page, you can see when starting a conversation about driving risk with a person with dementia, show compassion and empathy. Think about how it would feel to no longer be able to drive. Share your thoughts with them about what it would be like for you, and encourage them to talk about what does it mean to them. So have a conversation, open it up. Don't make it sound so easy, because for the person with dementia, it usually isn't. And have ongoing discussions about driving risk. There's some worksheets and some videos that we share with people. A healthcare professional, an OT, perhaps an OT who's new to this field, or a physician who's training, or even an experienced physician. It doesn't matter how experienced you are. This is not an easy situation, and there is no right or wrong answer for these assessing fitness to drive options. There is a lot of gray areas. And so one of the things we try to teach on our provider portal is an approach to assessing fitness to drive, where it's a standardized approach and allows you to have a big picture approach about the person's driving. Now you can see the language here that is geared for healthcare professionals. So it's much more sophisticated, much more dense, but hopefully people find it practical. And we're doing some work assessing the response of healthcare providers to this part of our portal. So use a comprehensive approach. Here's a stepwise approach. So assess the type of dementia, the functional impact of the dementia, other medical and psychiatric comorbidities, take a driving history, do a cognitive assessment, conduct a physical and neurological examination, interpret the findings, and formulate next steps. By the way, next steps are often arranging a specialized road test that a different type of OT may be involved with, one that's not intimately connected with the clinical team, but a specialized OT that does functional driving assessments in the community. In the window that I'm showing you, assess the functional impact. It talks about, and of course OTs know more than any other healthcare provider about functional impact, but the functional, so we describe here for all health professionals what the impact of ADL and IDL impairment might be on cognitive impairment. And according to the Canadian guidelines, if any basic activity of daily living is impacted due to cognitive impairment, the severity of dementia has progressed to the point where they just cannot drive. And then the guidelines also suggest if 2 or more IADLs are impacted due to cognitive impairment, but no basic ADL impairment, it's likely the person's impaired as well, and a comprehensive driving evaluation is strongly recommended. And by the way, I mentioned formulate next steps. A comprehensive driving assessment is not always the next step. So if they have severe impairment of function, as it says in the window here, it would be a waste of money to get a driving test, because they shouldn't be driving anyway. Learning about transportation options and reporting. We have links to the various provinces websites about what the rules are for healthcare professionals reporting dementia diagnoses. And so that's a tour of the website itself. And I'll just describe briefly what our plan is now. So we launched the Dementia Driving Roadmap in mid-October. And what we really want to do, first and foremost, we want people to use the website. So please share it with your patients, with your colleagues, with the family members of your patients. Think about using it yourself, either directly to learn some strategies or to share with your patients and their caregivers. So we have some research questions. How is the DDR taken up in the real world? How is it adopted and utilized? How does the DDR impact the way users approach and manage driving cessation? Does this make any difference? So we'll be using Google Analytics, looking at who's using the website and when, and what parts of the website are of interest to people. There are surveys that are embedded in the website, and we'll be inviting people to participate in interviews on the website. There's a link that says your feedback is wanted, and if you click on that and have an interest in being interviewed, there's a email address to contact our team to potentially set up an interview to really dive deeply into how does the DDR work in the real world and what is the impact. So that's the formal presentation. This is the link. The link has been active since October 18th. If you have questions, if you have feedback about the website, please provide it on the website. If you have people that if you have people that are interested in participating in research on driving and dementia, we have a study that's going on about autonomous vehicles. That really only works for people in the Toronto area. So if you have colleagues in Toronto who have patients that are working with dementia and you think that they might have interest in getting people into simulated autonomous vehicles, we've got options there. If you're a healthcare provider, which most of you are, and you want to help us pilot an education intervention that we're also going to be launching early next year, we would love to hear from you because we'll be recruiting healthcare providers to learn about driving and dementia in a different way than the website. So with that, I'll thank you and welcome questions.
Thanks so much, Gary and Mark. First question is whether or not your slides can be made available.
Yeah, we'll make sure, Robin, to get you a PDF of the slides.
Thanks so much, and we will get those distributed. We're also recording today, so if you have people who were not able to participate, we will be posting the link for this recording that you could send along to anyone who wasn't able to attend. Question from Bonnie, can you comment on any differences you found in resources to support driving cessation between rural and urban settings?
Yeah, go ahead, Mark.
I was so excited when Gary offered to take this question because you may have more to say, but this is a major gap in rural areas. Not only are there the transportation alternatives may be fewer than in, for example, Uber and Lyft don't work in rural areas. Our even access to our website may be limited in many rural parts of Canada. They just don't have the high-speed internet with which to access the website. So there aren't specific rural resources that we share on the website, but we do talk about the challenges in rural areas. We're also finding in some of our qualitative work, we're finding that there are some positive aspects to this journey that people in rural areas have that urban cousins don't have. For example, the tight-knit community that all comes together to help people. That doesn't exist in many urban centers. That's something that has been highlighted by some of our rural participants in our studies.
This is clearly an area that Mark and I have an interest in trying to support. We participated in a chapter writing about this issue in rural communities and acknowledge challenges. Mark alluded to some, certainly with respect to functional driving evaluations, such as those often conducted by occupational therapists in some rural communities. The irony is they have to drive for like an hour and a half to a center to have their driving assessed. So issues of access are challenging. I think, as Mark sort of alluded to, with respect to rural communities, I don't think there's a one size fits all, but really important in smaller rural communities, as Mark alluded to, sort of a coming together and the community helping to provide perhaps a solution. You know, there's no taxis, there's no public transportation. You know, there could be, many kilometers to, the nearest healthcare, or even grocery shopping, etc. All of these pose major challenges. And we have to recognize a certain truth, which is an unpleasant truth, that in certain circumstances, people have to consider moving because the community can't come together in a way that can support them where they're currently living, and they can no longer safely drive, and may need to consider alternative places to live, which is asking a real lot, particularly if someone's already dealing with the issue of dementia. But we need to be realists, I guess. So we want to be very clear. We understand that the challenges could be much greater in rural areas. And Mark and I do collaborate in research with a group in Saskatchewan whose main focus is managing dementia in rural communities. And this is an issue that we have discussed and will continue to focus on.
Thank you. Just a comment from an OT student who was able to observe some of the assessments in a more rural setting. At least here in Alberta, it seems that there are very few driving assessment opportunities. If a tier 2 driving assessment had been recommended, often it's just not available, not easy to access.
Yeah, so I sort of alluded to that in my response to the previous question. So look, this is clearly a problem, and advocacy can be one thing, but these are businesses, right? These driving assessment centers are businesses, so they need to make a business case. So presumably it's hard to encourage some of them to make this access available in smaller rural communities. But Mark and I are well aware of that the solution to this is really around the corner, because there's been a strong move to instrumented vehicles as a way to assess driving, with many feeling there are many advantages, including a person driving in their own car and driving in locations that they tend to typically drive in. Mark and I have had many discussions about this. We think that there's a strong likelihood that that's the direction that this will go in, and that will provide the solution for rural communities, because increasingly the technology to instrument cars is getting less and less expensive and easier to administer. And once there's a bit more evidence to what parameters can be measured with instrumented vehicles, that will help result in or provide solutions regarding safety or lack of safety to continue driving. I think that this is likely in the not too distant future to be a solution to this problem.
Thank you. And just a comment from Joanne that the resource could potentially be used for other individuals with driving challenges, like physical or mental health issues, or elderly without dementia. So do you find that it's going, or it's pretty new, but it's being used beyond people with dementia?
That's one of the lovely things. We've built this for dementia specifically, and it took 7 years to do this process that Gary and I highlighted. So to develop it for people with mental health issues, well, there's lots of different mental health issues that affect driving: depression, anxiety, ADHD, for just a few examples, and then many physical health issues with just a few examples of Parkinson's, obstructive sleep apnea, diabetes. Each of these are very unique, and lots of detail would need to go into a website to develop it specifically to that. We don't have the bandwidth or the time or funding to do that, but the lovely thing is that there are resources that can be used. It's not meant that way, it's not developed that way, but if people have to stop driving because of sleep apnea, well, some of the resources about how to keep active and how to maintain a good quality of life after driving cessation can be used for people with Parkinson's or sleep apnea, just as they could, or schizophrenia, just as they could be used as by someone with dementia. So you'd have to bear in mind that the resources are not meant for that, the language isn't meant for that, but if people find it helpful, the only caveat that I would say is that if you're a healthcare professional and using it, or a family member using it for a person with dementia, let's be very clear when we recommend it that we're not, by virtue of sending them to this website, dementiaanddriving.ca, or sorry, drivinganddementia.ca, we're not saying you have dementia. We're saying you don't have, you've got sleep apnea or you have schizophrenia. But this website has some interesting things. The same way that when I refer people to the Alzheimer's Society, I refer people with stroke dementia and vascular dementia to the Alzheimer's Society. And I tell them, you don't have Alzheimer's, but the Alzheimer's Society has resources that really are helpful for people with vascular dementia. Just as an example.
Thank you. Question from Alana. Did your research find any benefit for the use of formal driving restrictions onto current licenses as a method of gradual driving cessation?
Thank you for that question, Alana. So the short answer is no, we haven't researched this. The other aspect to this is there's not a real good evidence base around the issue of restricted driving and its effectiveness at reducing, for example, collisions, as an example. As Alana noted in her question, people often do self-restrict to a certain extent. And I think part of the challenge with restriction is, the majority of collisions that older adults and older adults with dementia end up in are often at intersections in their neighborhood. So there's a bit of a misconception, like many people say, well, why don't you just prohibit them from driving on the highway? Well, the reality is the majority of collisions for this age group do not occur on the highway. They occur at the intersection when they're going to their local grocery store. So to me, the question becomes, well, what restriction is sufficiently adequate to prevent them from having what we're all trying to prevent from happening, is potentially being involved in a collision that will result in injury or worse, fatality to themselves or others. So that's where I see the problem is with restricting driving. I think in the earlier stages where people still remain safe, it is useful to get people to restrict, largely because you're helping them on a path to stop driving. So at an early stage when they're still safe enough to drive, is encouraging them to start with alternative means to meet their transportation needs, so they start becoming more used to doing that. So then when it reaches the point that they're unsafe to drive, they've had some experience, and it's not an abrupt switch to I do almost all my meet all my transportation needs by driving myself, to using other means, so it's more acceptable. So it's in that context, while they're still safe and helping, encouraging them to restrict, that it helps them on the path to stop driving.
Thank you. And a comment question from Matthew. Edmonton's current city council is making attempts to improve options and accessibility to options for active and or public transportation. So he's just wondering if you feel it would be of benefit that your research and this resource could be made known to municipalities. It's evidence-based, and it might be helpful to cities in their efforts to continue to improve alternate transportation options.
Yeah, I mean, a great question, and I'll let Mark chime in. So Matthew, I mean, yes, in the sense that several of the systematic reviews, for example, that we published as our qualitative studies that we published based on developing this, clearly show how people feel that they have inadequate transportation alternatives often. So it does point out the various challenges. It points out how really emotionally difficult having to give up driving is, and the challenges that it poses for them. So to the extent that the research work that we did in preparation for developing this resource would support and encourage municipalities and city councils to recognize the importance of this and perhaps support alternatives to support people with disabilities in general, and certainly people with dementia. I think, yes, that some of the work that we've done could certainly support that.
Thank you. Any additional questions? I'll just wait a few seconds here before we wrap up for today. Hearing none. Gary and Mark, thank you so much for sharing with us today. Thanks to everyone for attending, and we will make this recording available. Please go on to the website and check it out more thoroughly on your own time, and share with others who can benefit. Thanks so much, everyone. Have a great afternoon.
Thank you very much for hosting us.
Thanks very much, everyone. We appreciate your attention.
Take care.
Bye.